Thank you very much for your kind introduction. And thank you very much for giving me a wonderful opportunity to talk about our cohort studies. Today, I'd like to talk about the plasma biomarker studies on cancer within the JPHC study. First of all, I'd like to briefly introduce our study. We call it the JPHC study. It's a population-based cohort, and including the 140 subjects aged 40 to 69 years old who lived in 11 public health center areas. As a baseline survey, participants answered the self-administered questionnaire and provide their blood and health check data in 1990 to 1994. So in addition to the baseline survey, we conducted a 5-year follow-up survey, and we collected the same information as the baseline survey. For the 10-year follow-up survey, we collected the questionnaire data only. In total, 130,000 subjects returned to the questionnaire, one of the 3 questionnaire survey, and about 60,000 subjects provide their blood at least one of the 2 sampling time. We followed all subjects since the baseline survey, and we collected the information on the residential status, cause of death, incidence of cancer, stroke, and myocardial infarction. So as of 2021, we have 43,000 death cases and 32,000 cancer incident cases. So regarding the collection of the blood samples, 10 milliliter prepared blood in heparinized tube were provided by the cohort members at the occasion of the health checkup program provided by the local government. The tube was centrifuged to obtain the plasma and Buffy code layers within 12 hours. And plasma and Buffy code layers were divided into 4 1 milliliter tubes, 3 for plasma and 1 for Buffy code. And they were stored at -80 centigrade. In order to use the studies with plasma samples, we applied both nested case control and case cohort design to the JPHC studies. I will show you the several findings from the both study designs, and first 2 examples came from the nested case control study of the pancreatic cancer. So it includes the 170 cases and 340 controls, and we performed the genotypings using the SNP chip, and we also conducted a metronome, proteome, and the metabolome analysis. In particular, I will show you findings from the branched chain amino acid and the metabolites identified early detection marker of the pancreatic cancer. So this is the first example for the nested case control studies, which examine the association between the BCAA level and the risk of pancreatic cancer. As you know, the branched chain amino acid has been shown to be a novel biomarker for obesity, insulin resistance, and the future development of the diabetes. And considering the established association of the obesity and the insulin resistance with the risk of pancreatic cancer, so a circulating level of BCAA could be associated with the occurrence of the pancreatic cancer. Here is the main results, and we found a statistically significant positive association between the plasma BCAA level and the risk of pancreatic cancer, even after adjustment for the potential confounders as shown in the slide. And the trend test was also statistically significant. Considering the design of the nested case control study, the blood samples were collected before cases were diagnosed with cancer. But the duration between the blood collection and the time of diagnosis varied according to the cases as shown in the slide. So if years between the blood collection and the time of diagnosis is very short, for example, 1 or 2 years, or within 5 years, the observed association might be affected by the presence of the cancer. So the observed association suggests that the diagnostic or early detection marker. On the other hand, we observed a positive or inverse association among the cases who are diagnosed with a cancer 5 or 10 years more after the blood collection. So these findings suggest that the risk or predictive factor. So when we conducted the stratified analysis according to the follow-up time, we found no association among the subjects who are diagnosed with pancreatic cancer within 10 years. On the other hand, we found a positive association among the subjects who diagnosed with cancer more than 10 years after the blood collection. So the positive association was stronger among the subjects who are diagnosed with cancer more than 10 years. So in the US prospective study, they also found a positive association, but stratified analysis by the follow-up time revealed that the significant positive association was observed in intervals of the 2 to 5 years and 5 to 10 years. This is the opposite result to ours. So the US group hypothesized a breakdown in the muscle protein in early pancreatic cancer, and it leads to the increased BCAA level. On the other hand, considering the previous studies have shown that the higher level of BCAA are associated with the increased risk of obesity and diabetes, deterioration of these risk factors, such as insulin resistance during the follow-up period, might account for the observed association. So here is a second example. We examined the association between the metabolites identified as early detection marker and the risk of pancreatic cancer. So our collaborator in Kobe University identified 18 metabolites which were significantly altered in the pancreatic cancer. Among them, we selected the 12 metabolites, as shown in the slide, which were stably measured by the quantitative procedures for these studies. In this study, none of the 12 metabolites found a significant association, as shown in this slide. However, considering that these 12 metabolites are candidates for the early detection markers, we conducted the stratified analysis among the subjects who are diagnosed with pancreatic cancer within 6 years after the blood collection. And then inverse association was observed for 4 metabolites, namely 1,5-anhydrode-glycidol, asparagine, tyrosine, and uric acid. So these findings are consistent with our previous studies, which showed an inverse association between the 4 metabolites and the presence of pancreatic cancer. And our findings suggest that change in these 4 metabolites might be a result of the existence of the pancreatic cancer. So in addition to the nested case control studies, the case cohort studies were also applied to the JPHC studies to primarily conduct the genetic analysis for total cancer. The case cohort design might be efficient in terms of the samples to be genotypes compared to the combination of nested case control sets for each cancer site. In addition, sub-cohort might be useful for conducting the cross-sectional analysis because the sub-cohort members were randomly selected from the original cohort. Actually, as I mentioned, we collected the blood sample about 50,000 subjects as a baseline survey. After exclusion of subjects in Tokyo and Osaka and ineligible subjects, a total of 33,000 subjects were eligible for the baseline case cohort study. we randomly selected the 13,000 subjects as a sub-cohort member, stratified by sex, age, and area. And by the end of the 2009, we identified 3,750 cancer cases. We performed the genotypings using the SNP chip for all sub-cohort members and all cancer cases. In addition, we selected the 4,500 subjects from the sub-cohort members to conduct the plasma measurement. Regarding the cancer cases, we have about 800 for stomach, 750 for colorectal, and about 500 for lung cancer. So here is an example of the case-cohort study, which looking at the association between the plasma vitamin D and the risk of cancer. The beneficial effect of the vitamin D on bone health has long been recognized, but accumulating the evidence suggests that the benefit may extend to other chronic diseases, including the cancer. So as shown in this slide, vitamin D offer the anti-tumor effect through the inhibition of the cell proliferation, induction of the apoptosis and the differentiation, and the inhibition of the angiogenesis and inflammation. According to the epidemiological evidence, circulating the vitamin D were associated with the decreased risk of colorectal cancer and lung cancer. Regarding the other cancer sites, including the cancer overall, remained inconsistent. And the evidence on this topic from Asian population is very largely limited, very limited. So here is the main result. We found statistically significant inverse association between the plasma vitamin D and cancer overall. So our findings support our hypothesis that the vitamin D have a protective effect against the cancer. So here is the result of the site-specific cancer. And we found a significant inverse association for liver cancer. And the suggestive inverse association was observed for lung, prostate, and biliary tract. But no association was observed for colorectal cancer. So in our study, we found no association for colorectal cancer, but a recent pooled analysis from the 17 prospective cohort study showed a significant inverse association, especially for women. So the reason for the no association in our study is not clear, but partly because of the insufficient statistical power, because our studies include only 630 colorectal cancer cases. For other reasons, the pooled analysis conducted based on studies mainly from the European countries. The association between vitamin D and the colorectal cancer risk might differ between the Asian and the European populations due to the difference in the lifestyles and the genetic background. So a key aspect of this pooled analysis is used for the category by the IOM guidance for bone health. So it shows the increased risk was observed among the subjects with the deficient level of the vitamin D, lower than 30 nanomole per liter. In addition, the level above the sufficient level, it means 75 to 100 nanomole per liter, was associated with lower risk of colorectal cancer for all subjects and women. And at the level of 100 nanomole per liter or greater, risk did not continue to decline. So it is very important to clarify those response patterns, and further such studies are required. So the second example for the case cohort study is the association between the CRP and the risk of cancer. So as you know, the suggested link between the information and the development of cancer has been growing. And the CRP is a well-known biomarker for the systemic low-grade inflammation, and it's used for the many epidemiological studies. So here is a summary of the previous studies for looking at the association between CRP and cancer. So majority of them show the positive association for cancer overall and lung cancer. But for colorectal cancer, breast and ovarian cancer, positive association was found for some studies, but overall their findings are inconsistent. Regarding the other cancer sites, only a few studies are available, and studies from Asian countries is very limited. So here is the main results, and we found a significant positive association between the CRP level and the risk of cancer overall. And the site-specific analysis found positive association for colorectal, lung, breast, biliary tract, leukemia, and kidney cancer. So we conducted the sensitivity analysis, excluding the subject who are diagnosed with cancer within 3 years. So overall, we found a positive association. And in particular, statistical positive association remained for cancer overall, and colon cancer, breast, and biliary tract, and kidney cancer. So in this study, we confirmed the positive association for cancer overall and colorectal and lung cancer. And in addition, we provide the evidence for the biliary tract, leukemia, and kidney cancer, which have not been studied well. Today, I showed several examples for the single measurement for the biomarkers in the JPHC study. But these biomarkers might change during the follow-up period, even if they reflect the long-term exposure. So the studies using the repeated measurement are required. As I mentioned, we collected the blood sample in both baseline and 5-year follow-up survey in the JPHC study. So we also constructed the case cohort studies for total cancer using the data from the 5-year follow-up survey. Actually, about 30,000 subjects who responded to the questionnaire and provided the blood sample at 5-year follow-up survey. Among them, we selected about 5,000 subjects as a sub-cohort member, which a similar number of the cases identified during the follow-up period by the end of 2015. So actually 60% of the subjects in the 5-year follow-up survey were overlapped with the subject in the baseline survey. So it means that we can use both information on the baseline and the 5-year follow-up survey for those overlapped subjects. So we are able to assess the association between the change in blood level and the risk of cancer. In addition, these repeated measurements might reduce the bias due to the measurement errors. Actually, we completed the selection of the subject, and we picked up the plasma sample from lymph users, and now we have planned to measure some biomarkers which have done in the baseline survey. So here is my summary of my talk. The JPHC study is ongoing cohort, and the repeated questionnaire data and the plasma and the DNA sample were available. We conducted several nested case control studies, and in general, the observed association indicates risk of predictive markers, but the stratified analysis by the follow-up period might be useful for the investigating the diagnostic or early detection markers. We also conducted case cohort studies for total cancer, so we can assess the impact of the well-known markers on total cancer risk among the Japanese population. And the site-specific analysis confirmed the association of well-known markers with the risk of well-studied cancer sites. And in addition, it may clarify association of site-specific cancer risk which have not been studied yet. That's all for my talk, and thank you very much for your kind attention.